Jaime is the Program Director of Community Reach Centers for Crisis Programs in Colorado. She has a master's degree, and I thought this was fascinating, in international disaster psychology. One of her notable accomplishments, and they are many, is that she created a community mental health training program in Liberia. She's done crisis work since about 2010, but she really believes that she has been training for this work all of her life because her mother is a crisis magnet. And with that, I will introduce Jaime, who's going to talk about reducing referral denials. And this is really important stuff.
Thank you, Mindy. Okay, well, thank you guys all for coming to this amazing conference, and a huge thank you to Travis and Laura and Remy at TPD Solutions for putting this on. A chance to, I know I did this yesterday, but get up and stretch your legs. Almost everybody. Okay, I'm going to ask you all to stand up again one more time. I think it's important that we get a little bit of movement, right? Before we jump into our next thing here. So this time, what we're going to do is we're going to all stretch to this side. Okay, stretch to this side. Up to the ceiling. Down low. All right. Now we'll give her some pat on the back. So as Mindy said, I am going to be talking about reducing referral denials by staff. This was a complicated title to try and figure out how I was going to communicate what this presentation was about. We're going to talk a little bit about data methods that I've used at my organization and ways that you might implement a similar system and why it would be important to do so at your organization. You'll have to bear with me. I don't usually use note cards and I don't usually get out of breath, but baby brain and pregnancy have caused both of these things to happen, and so I'm going to rely a little bit on my note cards and remember to breathe. Just a bit of an introduction, a little bit more on myself. Like Mindy said, I have my master's in international disaster psychology. I've always been interested in wanting to work with individuals who are experiencing crisis, who have experienced trauma in their lives. And that's really what drew me into this field. So, I completed a mental health training program that we delivered in Liberia and West Africa to individuals that knew nothing about mental health. Learned some interesting things there, like they have a cultural diagnosis of what's called open mole, which is a belief that there's a hole in the top of your head that demons have entered into, and that sometimes causes symptomology. So some interesting cultural information for you guys. Probably never knew that before. If you knew that before, you would be amazed. I also spent time working with refugees and then doing in-home family therapy with kids who are at risk of being removed from the home. About 4 years ago, I made my way into the crisis residential arena and started my journey in leadership there. So worked a little bit as line staff, supervisor, manager, and now I am the director overseeing 4 of our crisis programs. All right. So our learning objectives today, we're going to again talk about what my organization has implemented to help reduce the amount of denials that we are seeing from staff based on criteria or based on other reasons that our staff like to give for wanting to deny someone from our program. I think it's been interesting to hear a little bit about what some people have talked about with risk aversion, right? And how do we deal with risk aversion in our staff? So hopefully you guys will be able to take away from this ways that you can implement a similar system in your programs. And as you'll notice, 3 of our 4 objectives all revolve around data. So it's a data-filled morning for us. So why do we like data, right? I think it's important to know, first of all, why the heck we measure data. Who likes data in here? A couple people, about half the room maybe. The other half are like, no, I don't want data. I just want to work with people. So data gives us a way to have better informed decisions. we have measurable outcomes, and we have a higher chance of success when we use data to inform our decisions and the ways that we break down barriers. Okay, so we're going to talk about what data do you need to collect in the system, how do you collect that data, how do you review the data, and what do you do with it, and then finally I'm going to talk about the way that we used our data to then form a partnership with primary care physicians and other physical health providers on the horizon for us. All right, so set the stage a little bit and tell you a little bit about my agency. Community Reach Center is a CARF accredited agency. It's been around for about 60 years. We serve the Adams County region of Colorado, which is just north of Denver. When I mention CARF too, I think it's important to say our entire agency is CARF accredited, and our next phase is getting our crisis stabilization unit specifically accredited under CARF for that accreditation there. We provide a lot of services, and you'll get to see a bit of our continuum from what we say from cradle to grave. And under our crisis continuum, we have a mobile crisis team. We have a crisis walk-in center that both of those teams serve anyone 24/7 in the community, in an emergency room, on a street corner, or anyone can just walk on in. We have therapists, peer specialists, case managers that can work with individuals. We then have a crisis residential respite services, which operates out of a house that has 7 beds. And then our crisis stabilization unit, which I'll be focusing more on today, and give you a little bit more information about that. So here is our care continuum at our agency. Like I said, we have a lot of different services. We have about 600 employees, so we're a pretty large organization and nonprofit community mental health center. All of our crisis services fall under our high acuity section here, but we do try and refer out as much as possible to all of the other services that people can be receiving once they hit our crisis services, make sure that they are staying stabilized once they're seeing us. So the method that I'm going to be talking about in terms of data and referrals and denials really was developed in our crisis stabilization unit, but we use it both in there and in our crisis residential respite. The reason why I'm going to focus on our crisis stabilization unit is because we have seen the biggest impacts happen in that program. So out of curiosity, how many of you guys struggle with keeping your beds full in your programs? Okay. So some of you, I know in our residential respite, we actually usually have a wait list, and in our crisis stabilization unit, we usually have empty beds. So we see both sides of that problem. So our crisis stabilization unit is a 16-bed facility serving adults 18 and up. We like to call ourselves a secured but not locked facility, meaning that we can take individuals on involuntary commitments. However, if they choose to leave, they can. We'll just know it because the alarms will go off on our doors. We have a maximum length of stay of 5 days, and that's dictated by our crisis contract that we have with our state. Although you'll see our average length of stay is 5.27 days. That's because we try and fudge the numbers a little bit and we count in 24-hour increments and not by an actual day. That's how we get away with that 5.27. The primary focus for individuals on our unit is a self-defined behavioral health crisis. So they do have to have a DSM-5 behavioral health diagnosis, but really for them, it's whatever they are experiencing that's preventing them from operating in the community without 24/7 supports. Once they're admitted to our unit, we do ask that they stay until they're ready to discharge. So we don't offer passes into the community and they can't come and go as they please. More specifically, and I'm not going to review all of this, but this is some of our clinical criteria. The way that our referral system works is that we receive a fax referral or an email referral from multiple different sources. Could be emergency departments, other walk-in crisis centers that are across the Denver metro area, other mobile crisis teams. And then we have specific admissions coordinators review that referral that's sent to us for our clinical criteria. And simultaneously, we have nurses review our medical criteria. So we do have some set medical criteria. One of the interesting things, I don't know if anyone can relate that has multiple programs, is that sometimes I find in a program where we have 24/7 nursing, medical criteria is stricter than in a program where we only have nurses 7 days a week. I don't know if anyone else has experienced that, but it seems like one of the areas we really have to dig in and work on that risk aversion is with our medical staff in particular.
That's a good question.
Yeah.
Why don't you take them on Suboxone?
We don't have, in our CSU, we don't have providers that are licensed to administer Suboxone or to prescribe Suboxone.
I got you. But so if you did, you would take, it's not has anything to do with the drug itself or reactions or anything, it's just the licensing.
Correct. Yeah. Yeah, you'll notice that we do have, for anyone who's familiar with a CWA score, that's a medical scoring tool for alcohol and benzodiazepine withdrawal. So we do have a protocol where we can help individuals withdraw from medications or from alcohol while they're on our unit, but we have some criteria around our CWA score. Interestingly, we also run a detox unit, and their max CWA score is an 8. So we can take sometimes higher acuity individuals who are withdrawing that our own detox can. That's because we have 24/7 nursing and they don't.
And over in your detox, then do you have somebody that's licensing for Suboxone or not at all?
No, and our detox is a complete social model. So they don't do any medical assisted detox. Yeah. A bit about our staffing patterns. So during the daytime hours, we have 2 therapists, an admission coordinator, a peer specialist, a case manager, 2 mental health techs, 2 nurses, and a provider Monday through Friday. So we're heavily staffed 7 days a week, and we are fully running all the time. We have lots of activities between groups. We run 3 groups a day formally. Then we have informal peer-led groups in between that time. Each individual meets with a therapist at least once a day, meets with a case manager as needed, and then meets with our nurses usually once or twice a day. And they get an evaluation by our prescriber, who's currently an NP, within 24 hours of coming into the program, and then as needed as they go along. 16 cents. So to hop back a little bit on referrals, an interesting note about our referral system is that we will review referrals 24/7 and clear or deny them. However, we only receive consumers onto our unit between the hours of 9 a.m. and 8 p.m., and that's currently due to staffing and some interesting things that happen with insurance and payment when you accept someone after 8 p.m. And you only get to treat them while they're sleeping, and you lose a day of payment there. So we typically, on the overnights when we receive referrals, we'll still clear that individual, and then we'll schedule them for admission at 9 a.m. the next morning. Okay. So let's talk a little bit about our ideal, the reality, and the problems that we sometimes encounter in our units. So when we opened 4 years ago, our hope and our ideal was that we were going to reach this really underserved population of individuals that didn't need inpatient, right, but that were ending up there after a while because their symptomology was increasing until finally they had nowhere else to go. By reaching that population, we would fill our beds, right, our census would be full, we'd be fully running, and that we would be able to maintain safety on our unit from the criteria that we had developed. So there we were, first year, arms open, ready to receive our consumers, and guess what happened? Well, our beds weren't full, right? We were sitting around going, where are all of these individuals that we know would truly benefit from this service? So we dug in a little bit, and we looked back at all of our referrals, right? Were we not receiving enough referrals? And you'll see a slide later on that kind of gives you a graph of number of referrals we receive. Well, typically we receive somewhere between 150 and 200 referrals a month. So it should be enough to fill our census, right? So what was the issue? Really, we found that the issue was that we were denying people from having access to our unit, either due to the criteria that we had outlined, or because staff felt like they were too risky to manage safely on our unit. So that became an issue, right? So here we have the reality. Like, referrals are outside our criteria, we're trying to balance the safety of the unit with serving our community need, and then because we're not filling our census, we're falling short on our budget. So we had to think of what were the problems and how we were tracking this. So we had a lack of data and metrics. We had no idea who was being denied, why they were being denied, when they were being denied. We had to think about where do we start to gather that data, and then how do we make an impact and actually reduce the number of denials that we have. So what's the solution? Well, there's a lovely screenshot here. Data, analysis, and ideas. So this gets back to who loves data and who doesn't love data, right? Ultimately, I think in your programs, one of the ways that you need to be successful is to have at least one person who really loves data, who really wants to collect that data, who wants to dig into those numbers, and who wants to then be able to regurgitate some of those numbers. Fortunately, that was me in my program, right? I'm one of those oddballs that was like, program evaluation, yeah, it's my favorite. And so I was brainstorming a lot about how we can really solve the problem and come up with a good way to do this. It didn't take too much staff time. So let's look at the steps of how we did this. Step one, just track your data, right? So we had to start with what data do we even want to track? We couldn't track everything under the sun because that would take away from our ability to clinically serve our clients that are on our unit. And so we had to really dig down to what was our purpose, right? And for us, using this system, now you can absolutely change this to meet your needs in your program, but for us in our system, what we wanted to do with this data tracking was understand why people were being denied so that we can break down those barriers and get them on our unit. We took referrals from the last month and we sat down and we looked at the top reasons why people were being denied, and we talked with staff about what influences their decision on whether to deny somebody or accept them into our program. Here's an example. Oh, that was not the button I wanted. Here's some examples of the data points that we collect on ours, and you'll see it in our referral spreadsheet. One thing that you'll note that's not on here that may be something that's interesting to you guys, and we are going to add in the future, is payer source. So, right, you might have the ability to track, once someone is admitted to your program, what is their payer source? But if you don't know who you're denying and what their payer source is, you might not know that you have a whole bunch of people that are getting referred from Kaiser, and that's who you really need to reach out to get that contract with, right? So this is a great way of being able to say where are the gaps that we need to go out and find. How do you collect your data? So there's a couple key factors that you really want to think about when you are talking about how you collect your data. How many of you guys use an electronic health record? Okay, this looks like about most people. If you have the capability of tracking your referrals in an electronic health record, I highly recommend that you go that route because it makes the data collection and interpretation a lot easier. You don't have to do it manually. Unfortunately, in our case, even though we have a nice electronic health record, it wouldn't allow us to track referrals from outside sources. So if an outpatient therapist within our own organization wanted to send us a referral, great, we could track that. But if an emergency department down the street wanted to send us a referral, we couldn't track that in our electronic health record without doubling our workload. So we decided to use an Excel spreadsheet. The way that we do it is that we have an Excel spreadsheet that's password protected and on our secured server so that it remains HIPAA compliant. And then multiple staff can go in and add data to it. Right? So that was the easy way for us to do it. And it cut down a little bit on staff time, being able to have multiple people go in and track data. It's not a foolproof method, so again, if you're able to use your EHR, or maybe one of you guys has an even better idea, and if you do, please let me know. Please use it. You can also use an Access spreadsheet. For those of you that are really familiar with Microsoft products, an Access spreadsheet is similar to an Excel spreadsheet, but it has some different functionalities to it.
Are you tracking just the denied referrals or accepted referrals as well?
We track all referrals. Yeah, and I'll show you a little bit about some of our outcomes and what that looks like. So again, things to consider: ease of data input. You really want to narrow it down. You don't want to have like 52 items that your staff has to track based on every referral. Think about what are the outcomes you really want to get to. How to aggregate your data into a usable form. So when we started in our spreadsheet, people were just like free form writing, oh, we accepted this person coming at 3 o'clock, right? And then I would go in and be like, oh my gosh, I have to look at 152 referrals and then put next to it whether they were accepted or denied, right? Made it really hard to track. Again, staff time kind of goes along with ease of data input. You don't want to make it too complicated for your staff. Our staff are already overburdened with the amount of data that they have to track, paperwork that they have to do. Make sure it's HIPAA compliant. I know we've had some conversations so far about HIPAA in this room, right? But that is something you want to ensure is in there. And you want to have a system for who records the data. So again, for us, it is during the daytime hours. We have master's level admissions coordinators who look at their referral. They enter all of the data into our spreadsheet. And then overnight, we've actually trained our mental health techs, which was a push that I had to make to say, yes, a bachelor's level person can determine whether or not someone's appropriate to be on our unit. You don't have to be a master's level to do that. So they clinically clear in the evening. And since we have nurses 24/7, they provide our medical clearance 24/7, and they enter that information into our data. Okay, this is probably really small, so I'm going to go through and explain, but this is what our spreadsheet looks like. So this blacked out column is the consumer name, obviously for privacy reasons. We have the name of our referral source here. This is really nice because, again, you can tell where the majority of your referrals are coming from. So if you want to do something really nice to your top referring source, you know who it is. Or if all of a sudden you get a referral in, a couple referrals here and there from someone that you've never heard of, you can track them down, give them more information about your program, and hopefully increase the amount of referrals you get from them. Date and time. This has become important for us because, as you'll hear later, one of our next goals is to ensure that it takes no longer than an hour for us to receive, review a referral, and get an answer back to our referral source. This column is usually mostly blank for us, but it signifies that sometimes we get a referral that says, I'm referring Jane Doe because she needs to be on your unit. Okay, great. Tell us more information, right? We don't want to start our hour clock, and so we have all the information we actually need to review. We have the date and time of a clinical decision, when that was made, and by what staff. So again, it was important for us to know how long was it taking to get to a clinical decision versus how long it was taking to get to a medical decision. And what we can tell from our data is that it takes about 15 minutes for a clinical decision to be made, and right now it's taking 2 to 3 hours for a medical decision to be made. It's also important that we have names. So you'll notice like, oh, Jess does a lot of our reviewals, right? She's one of our admissions coordinators. And here, Kirsten and Melissa, our nurses, do a lot of those reviews just because those are the days they happen to be at work. But that's important too so that we can circle back to specific staff if we have feedback to give them around the reason why they denied somebody. I love to color code things. So this category is our decision. What do we do with that referral? And I color-coded it to make it really easy to see. Obviously, red is that this individual was denied from our unit. Green was they were accepted. And blue is an interesting one because blue actually means one of three things. It either means that the placement is no longer needed, right? So the referring source changed their mind and they are sending this person somewhere else, usually back to the street. That the consumer declined coming to our services. So sometimes after we give our lovely welcome letter to them, wherever they may be, the consumer says, you know what, you don't have a TV in my room individually, so I'm not coming. So, okay. And then we have another blue category that's placement lost. Placement lost means another program accepted this individual before we could even get to reviewing it. We have denial reasons here. So you'll notice it's blank next to placement not needed or accepted. These are really just for the reason why someone was denied. A thing that we learned in our process about this was that we have to make these and these drop-down boxes, so it limits what information staff can put in there. Again, it really helps us to get clear data at the end and aggregate it well. So this one was denied for the level or type of service needed. That's indicating that we really thought that this individual maybe needed a medical detox, or they needed a specific group home for IBD. This one was for risk level. So risk level meaning that clinically this individual was outside of our clinical criteria. They probably need a locked unit. Some other ones that we have up here are outside of our substance parameters, right? So they're specifically CWA is too high or they have polysubstance use. No capacity. I like to see that one. That means that we don't have any beds. Consumer under the age of 18, right? We don't take anyone under the age of 18. So I have refined what the denial reasons are in the past 3 years since we've implemented this system to make it so I can really track the data that I need, right? And I can narrow down my numbers. Okay. So what do you do with the data? Now you have it. What do you do with it? So every day, either our lead or our supervisor sends an email to our leadership team with a list of who was denied in the last 24 hours. That way we can review it, make sure we're all in agreement. We don't need to follow up and maybe even try and track down a person to say, we made a mistake, we want you on our unit, come on. We break down the categories by trends and percentages, so you'll see some of these graphs. That was my job, I did it all manually. I love to do it, so I would recommend if you use this, you find someone that loves to do it, or you have a data team that does it for you. And collecting a baseline is important, right? So when you get started, make sure you give yourselves a couple months to have a baseline so you know if you're having an impact with any decisions that you decide to move forward. Okay, here's an example of some of our data results. So in December of 2016, we had 149 referrals that month. 54 or 36.2% of them were accepted onto our program. 66 denials, or 44% of our referrals were getting denied. We had lost 20% of them because we couldn't get to them soon enough. And then you'll be able to see it kind of breaks down all these other categories. And then I use graphs to show this data in another way to our leadership team. Here's the number of referrals that we have received each month, starting in December of 2016, all the way until July of 2018. Now, we haven't specifically looked at why this fluctuates or what are some of those reasons, but you could potentially get into that. But this is an example of the data that we get every month. I present this every month to our leadership team. So then we have to move the data forward, right? It's really easy at this point to go, great, I've collected all this data, I've done this hard work, I know my graphs and my percentages, and pat yourself on the back and leave it at that, right? But that would mean that you did all this hard work and you don't have really good outcomes to show for it. So what we do to move the data forward is every month, our leadership team gets together and we talk about what were the trends that were most important and were there any impacts that we were trying to make from the last month, right? So we'll talk about a specific example of that with our medical denials. In this meeting, then, we create action plans, and we have measurable data that we're looking for the next month, and we assign it to specific people, right? So we don't want to just leave the room with, you know, this person thinking that this person's going to do it, and that person thinking that person's going to do it. We come back next month and no changes. So make sure you have a really clear plan coming from your data. Don't forget to capture your successes. I'm that person that's like, what's our next project? What's our next thing? What's our next, right? And so I always have to remember to take a minute and like, oh yeah, our denials went down, and celebrate those successes, and bring it back to your staff, right? I think one thing that we have discovered is that our staff can get pretty wary knowing that their leadership team is reviewing every decision that they make. So we want to really make sure that it's clear to them that we are not micromanaging, we are understanding data and trends, and then celebrate successes with them. So thank you for doing all the hard work that you've been doing. All right, so one thing that we discovered in looking at our data was that medical denials made up the largest reasons why we actually denied someone from our unit. And when we looked at the notes, right, so we had our denial decision, our reason, and then notes on the side. When we looked at those notes of like why the nurses were making those decisions, a lot of it was blood pressure was out of range, or glucose was out of range, or they needed wound care, things that really could be solved by a primary care physician, and they didn't need to go to the emergency department to take care of that. So we reached out to Centura, which is one of the largest health providers in all of Colorado and Kansas, and we asked them, hey, what do you guys think about this data, right? We know that our consumers have a high utilization rate at your emergency department right next door. What would you say if we could find a way to get those consumers out of your ED and onto our unit? And in order to do that, can we use your primary care physician clinic, which is also right next door? And they were like, oh yeah, that's a great idea, right? Get them out of our emergency department. So we set up a system with them where 2 days a week, their primary care physician, 5 days a week, Monday through Friday, their primary care physicians come onto our unit and see our consumers that have physical health concerns. So this allowed us to say, we're going to still admit you if your blood pressure is out of range, right? We're still going to admit you if you need wound care. We're still going to admit you if you need eye drops because your eyes are dry, right? Things that we can't medically take care of on our unit. So this has been a really great partnership because it has made our medical denial percentages go down. So we started that project in August, right about here. So we were already seeing a little bit of a dip because we were working really hard on this. And as you can see, overall, the trend really went down in the first couple of months. We had a little spike, but overall, our medical denials have went down. You can also tell that no data is perfect, right? And so while we can attribute a lot of the reason why we have less medical denials to having primary care consults on our unit, there are also other reasons that we have to look at, like why do we have this huge spike in medical denials going up right here, right? One of those reasons is that we have a bunch of new nurses and we have not acclimated them to our culture of being less risk averse. So we have a lot of work to do with staff training to get that number back down. So next steps for us. How are we going to take this data and still continue to move it forward? We actually are now planning a partnership with integrative medicine where an acupuncturist is going to come onto our unit twice a week and provide acupuncture for consumers that want it. And then we're going to reduce our referral review time to under an hour, right? And again, we only know that these are working because we have data that's tracking it and we can measure the outcomes. So these are our projects that are kind of on the horizon for us. Okay. Make sure I'm kind of on time here. So learning objectives. Let's make sure we covered everything. What data do you need to collect? Raise your hand if you have an idea of what data you might want to collect regarding referral denials on your unit. Some people, not everyone. Okay, so I might have missed a little bit there. So again, what data do you need to collect? Why is that important? Right? You want to know who you are denying from your unit, and more importantly, just who you're getting referrals from so that you can better serve your community. That's the bottom line, right? There are people out there that need our services, and we want to be able to not turn them away as much as possible. How do you collect that data? Raise your hand if you have an idea of how to collect the data. More people? Okay. So hopefully that referral spreadsheet gave you some ideas. And again, implementing that in a way that's easy for your staff to use and easy to track. How do you refer the data? What do you do with it? So again, it's raise your hand if you have an idea about that. Okay, some people. Please feel free to ask questions. If you didn't raise your hand, if you don't know one of these things, let me know. Maybe I can help explain it in a different way. And then forming a partnership with primary care physicians and other health providers. I know I didn't spend as much time on that, so if you have specific questions on how we were able to accomplish that, also let me know. There were some pretty specific steps that we took to engage Centura in this project and ways that we had to incentivize them, right, to get them to agree to be in this partnership with us. So considerations and learning opportunities, right? Make sure that, again, you collect good baseline data. Without a baseline, you don't know if you've really had an impact. Staff turnover and training. We have discovered that it makes a really big impact on our data that we see each month. So when we go back and we review the last month's data, knowing how many new staff we have is really important. And then in that referral spreadsheet, if we've got a new staff that denied somebody, right, and we keep seeing their name pop up, it's a clear indicator for us that in supervision, we need to really go back and address that criteria and help them with that risk aversion piece. Having a backup system and giving room for human error. So it has happened more than once that someone has accidentally clicked delete, and there goes our spreadsheet, right? So work with your IT or IS systems to make sure that there's a way that your spreadsheet's getting backed up, and that you won't lose data, because that's a lot of work and effort that your staff are putting into the system, and you don't want it to just go out the window. There's also human error, right? So this goes into kind of patience and grace from a leadership level, is knowing that everyone's human, and sometimes staff forget to put in the denial reason, or sometimes staff put in a denial reason that doesn't quite make sense, and you go back and you ask them, and you have to really make sure that, hey, this is just from a curiosity standpoint, I'm trying to understand, I'm sure you had a good reason, like, help me with that. And every once in a while you find like, oh, did you know that our criteria actually says this instead of that? And did you consult with somebody on this? Because I understand where you're coming from, but it's not within our criteria, right? So kind of looping back around to staff in a way that feels still okay for them. And then changing data points. There's pros and cons to that. So like I said, I have changed the reasons why somebody can deny somebody over the years. And pros and cons to that, it doesn't help you with a baseline because your reasons are changing. So I've got 3 sets of data for the last 3 years with different reasons. However, we found that the pros outweighed the cons on that because I was able to give staff better, clearer definitions of what it meant to say somebody was clinically too high risk for our unit, right? And it helps them inform their decisions so they can really go and operate on their own. One of our sister CSUs in the Denver metro area, every single denial that they make has to go through their chief medical officer, right? And that's one way of managing your referral denials. However, that is very time consuming for a chief medical officer and might not be the best use of their salary. Right? When you think about that, I'm sure we all pay our CMOs a lot. So there's pros and cons to that system. All right, made it through. I'm gonna open it up to questions.
Hi, so, hey y'all. So our, in Tennessee, we had 8 crisis stabilization units, and statewide, our acceptance rate is pretty high. We have about a 95% acceptance rate statewide. The challenge seems to be not getting those referrals due to transportation. So we don't even get them to
Yeah. So we are fortunate in that all of our referral sources in the entire Denver metro area is on the same page that crisis stabilization services are needed and are willing to cab individuals who are voluntary from wherever they are to our unit. And so we just have that current agreement. If someone is involuntary, then for our state statutes, they have to be transported by police or ambulance, and so we try and always do it via ambulance. We don't want to burden our law enforcement and have extra stigma added on. But what we do find, I can tell you, I oversee our cab voucher budget at our agency, and it is quite large, and it's not something that we get reimbursed for. So we have to figure out as an agency, how do we absorb the cost of us sending someone from our walk-in clinic to another CSU if they're being accepted there. For example, to go from our, we call it our WIC, from our WIC to the CSU that's in Fort Collins, it costs us $135 to do that via cab. And we do that about 3 times a month. So we just have to, we're figuring that out as an agency, how do we absorb that cost?
I'm from Virginia. One thing that I've had to start tracking is bed cancellations in an effort to report this back to stakeholders, where we, hold a bed for a certain amount of time for someone we believe is coming, and then they call and say, actually, we're not going to need this bed anymore, and then track that reason and then report that data back to the leadership team and to our region that's composed of, in Virginia we call them community service boards, so county mental health centers. So that's something that has somewhat impacted our utilization. Is that something that you've run into in terms of having just to impact your census, or do you guys stay full without any problem?
So every once in a while, we do see under our category of placement no longer needed, a section in the notes that says, accepted, cleared, and then this client never showed up. And so we can see that in our notes. It doesn't have a big impact on our referrals. It's a very, very small percentage of the referrals that we accept where that ends up happening.
What's the hours of the PCP?
Sorry, what was that?
The hours of the PCP.
The hours of the PCP. So they reserve 2 20-minute consult slots Monday through Friday on our unit so that they can come and see us. We haven't found a need for more than that, but if we did ever run into a need, Centura is actually very good about working with us on being able to increase those hours. And part of that reason is because they bill for it, right? So they bill for that visit to themselves and they get that revenue.
I was thinking about the denial things, and what we've done is the folks doing the direct work, they don't do the reviews at all. So it can be completely unbiased, and so that really helped in one of our contract programs for intermediate care beds. Excuse me, they took it out of the clinician's hands, and so there's very few denials at this point.
Yeah, one way to do it.
Do you actually have like a guideline form or criteria that helps staff determine risk?
We do. We have a standard operating procedure which lists out all of our outlined medical and clinical criteria. And again, if there's anything, so staff have to deny for a reason that is listed in that criteria. And if they want to deny for a reason outside of that criteria, it can only be done with the approval of the manager.
Well, the specific denial reason is risk. Are there risks listed in that?
Yes. So if you're interested, I can show you kind of how our format lays out. We have the criteria written with what those risks are, and then we've created a color-coded scale to also help our staff indicate like this person is within this range, or the green range is all good, or the red range is outside of our risk ability. Some of the biggest ones that we see are an individual has had to have chemical restraints in the emergency room within the last 24 hours because of their aggressive behavior. So that's usually a risk one. Or this individual is on an involuntary hold and they ran out of the emergency room within the last 12 hours. Cops had to bring them back, right? Since we are now a locked facility, they're not appropriate for us. So those are some of our bigger ones. Anything else from anybody?